Hello doctors. So today we'll be seeing the INICET May 2024 Medicine Recall session. Okay, this is Dr. Karthikeyan, Medicine Faculty at Speed Institute. So coming on to the first question, two ABG questions were asked. So ABGs are like unavoidable when it comes to INICET as well as NEET. So this question was a patient with recurrent vomiting, ABG was given, pH was 7.5, PCO2 was 50, bicarb was 30. So here they asked what is the diagnosis? Straightforward question. So you should remember the normal values first. pH 7.35 to 7.45 normal value, single value 7.4, PCO2 35 to 40, single value 40, bicarb normal value 22 to 26, single value 24. So if first step is always look for the pH. If pH is more than 7.45, then it is alkalosis. To see the component, check for the bicarb component. It is more than 24, then that means it is metabolic alkalosis. And since the patient is having recurrent vomiting, he would have lost a lot of HCl in his vomit that might have contributed to the alkalosis. Next question was ABG, pH was given 7.34, sodium 135, chloride 93, bicarb 20, random blood sugar 420. Diagnosis they asked. Here also, first step, look for the pH. If pH is less than 7.35, then it is acidosis. If it is more than 7.45, then it is alkalosis. Next step, you should check for the metabolic or respiratory part. So bicarb, if it is less than 24, it is metabolic acidosis. Or if PCO2, if it is more than 40, then it is respiratory acidosis. Here it fits into metabolic acidosis. After going into metabolic acidosis, you should always calculate the anion gap to tell an ABG to be normal or high. So here, if you see the anion gap, what is the concept of anion gap? In our body, the number of cations is always equal to the number of anions. But if you take the measurable anions, it is the sodium. Okay, and if you take the measurable anions, they are chloride and bicarb. See the pillars there. If you subtract the measurable cations, sodium, with chloride and bicarb, you will get that gap of unmeasured anions. This is called the anion gap. So thus the formula exists. What is this formula? Sodium minus chloride plus bicarb. So normal value is 8 to 12. Single value 12 you should remember. Here if you apply the values given, it comes to around 22. So it is high anion gap metabolic acidosis. So the answer is high anion gap metabolic acidosis. Yes. Next question. ECG of a patient was given who is unresponsive. They gave one more statement like altered sensory. So the next best step they have asked. So A, amiodarone, B, digoxin, C, DC cardioversion. So what you want in this ECG question is, I want you people to know the analysis of a tachycardia in an ECG. How to approach a tachycardia? First, check for the heart rate. If the heart rate is the distance between two RR intervals, if it is less than 3 large boxes, then heart rate is more than 100. First step, tachycardia. Next, you should check for whether it's a narrow complex or wide complex tachycardia. So for this, you should check the width of QRS. So if it is occupying 3 or less than 3 small squares, then it is a narrow QRS tachycardia. If it is occupying more than 3 small squares, then it is wide QRS tachycardia. Next step is to check for the rhythm. Whether the distance between RR intervals is same or whether it is varying, regular or irregular. Next, check for the P waves, whether they are present or absent. So coming on to this question, if you see, first there is tachycardia. Next, the QRS width is less than 3 small squares. So it is a narrow QRS tachycardia. And then the rhythm, if you see, distance between RR is varying. So this is irregular narrow QRS tachycardia. If this comes in your exam, only 2 possibilities are there. So here you should check for the P waves. If P waves, if you find three more than different morphological P waves, like one by one P waves morphology is varying, then this we call it as multifocal atrial tachycardia, MAT. If you can't find any P waves, or if there is a fibrillary P waves, then the diagnosis is atrial fibrillation. Okay, so irregular rhythm, only two diagnoses, MAT or AFib. If it is a regular rhythm, then look for the P waves. If P waves are absent, then that means your tachycardia is originating from the AV node. So it can be PSVT or the famous AV nodal re-entry tachycardia, AVNRT. Okay, or if the P waves are present and it is present in the 2:1 fashion with sawtooth P waves in lead 2, then the diagnosis is atrial flutter with 2:1 AV block. Or if you find P is to QRS ratio, every P is followed by a narrow QRS, then it is sinus tachycardia. Okay, so in our exam, the ECG given was atrial fibrillation. P waves were not seen. So atrial fibrillation. So what we discussed in our revision class is any hemodynamically unstable tachycardia, except sinus tachycardia, your management should be DC cardioversion. Okay, so here hemodynamic instability like BP less than 90/60 or altered sensorium in heart failure, all these, the treatment of choice will be DC cardioversion. If there is pulse, then it's DC cardioversion. If there is no pulse, then same thing we call it as defibrillation. Okay, yes. So the treatment of atrial fibrillation is most important when it comes to NEET also. So let's understand this. If hemodynamically unstable, it is DC cardioversion. If it is hemodynamically stable, then there exists a question whether to convert the rhythm into regular rhythm or whether we should do rate control. This question is decided by the clinical scenario. In the exam, if they have given, like the patient is very young, okay, very young patient, less than 35-year-old, and the patient had new onset AF, first episode of AF, the duration is less than 48 hours. In such conditions, we should always give one try of rhythm control. Then, if it is a rheumatic heart disease where there is severe mitral stenosis causing severe dilatation of LA, here, even if you convert the rhythm, they will always go into again atrial fibrillation. So here, rate control is preferred over rhythm control according to latest ESC, ACC, AHA guidelines. So rate control, how to rate control? First is see for the ejection fraction in the question. If there is LV dysfunction, then your answer should be either amiodarone or digoxin. LV dysfunction means ejection fraction less than or equal to 35%. If there is no LV dysfunction, like EF in the normal range, 35 to 40, more than 35 to 40, then we can give beta blocker or calcium channel blocker. If there is any contraindication to beta blockers, like patient is in case of asthma, COPD, they prefer calcium channel blocker or beta, like cardioselective beta blockers, like bisoprolol can be tried. Next is rhythm control. Agents for rhythm control are class 3 as well as class 1C antiarrhythmics. Okay, yes. So now let's see the next question again on atrial fibrillation. It was correct statement regarding atrial fibrillation management is A, rarely seen in heart with normal morphology. B, discrepancy in pulse rate and heart rate are reliable for diagnosis. C, only digoxin used for rate control. D, cardioversion must for all case of atrial fibrillation. So here I want to clear out, like now only we saw drugs for rate control, we had 4 group of drugs. It is not only digoxin for rate control. That option is ruled out. Next, cardioversion must for all case of atrial fibrillation. Here also we saw like only in those atrial fibrillation who is young, first episode AF, recent onset AF, where like rhythm control should be given. Like cardioversion can be chemical or it can be DC cardioversion. So only there it has a role. Or else if you do cardioversion in a patient of rheumatic heart disease where the left atrium is chronically enlarged, patient having chronic atrial fibrillation. So what might happen is if you rhythm control, what will happen? First the patient was in atrial fibrillation. He might have had due to stasis blood clots formed in the left atrium. Now what you are doing, if you do cardiovert, what will happen? The rhythm will come back to sinus rhythm. Now P waves start coming up in the ECG. Now atrium will contract efficiently. Now what will happen? Whatever clots, micro clots which are formed in the left atrium and left atrial appendages will be embolized, and this will cause stroke or TIA in such patients. So only cardioversion is not a must for all cases of atrial fibrillation. This you should know. Next, rarely seen in heart with normal morphology. No, because it is seen even in hearts with normal morphology. Like most common cause of atrial fibrillation, non-valvular cause is hypertension. So it is seen in normal morphology, hearts also. It is not rarely seen. Only thing is discrepancy in pulse rate and heart rate. This is called what? Pulse apex deficit. So this is reliable for diagnosis of atrial fibrillation. So B is the correct statement. Next, which of the following is correct regarding CPR? So CPR guidelines, again we have discussed in our revision class. What you should know, first thing is, first management is always CAB. Circulation first, next airway, next breathing. This is the protocol followed in India, and this is the latest protocol as per ACC AHA guidelines. So first thing, patient is unresponsive, pulseless, start CPR. CPR has been started, then check for the rhythm whether it is shockable or not shockable. If it is shockable, like if the patient is having VT or a VF, then what you can do, give shock, then do CPR for 2 minutes. Followed by what you should do, check for the rhythm again. If it is shockable or non-shockable. If it is shockable, again CPR for 2 minutes. Here you can give epinephrine every 3 to 5 minutes. And dosage is 1 mg IV or intraosseous dose every 3 to 5 minutes. Next, after the third shock, you can give amiodarone. Dose, first dose 300 mg IV bolus. Second dose is 150 mg. Or lidocaine can be tried, 1 to 1.5 mg per kg is the first dose. Then again look for the shockable rhythm or not. This should be continued till the return of spontaneous circulation happens. If it is non-shockable like asystole or pulsed electrical activity, only treatment is your CPR only till the spontaneous circulation returns. So here, how is the quality of CPR? You should push hard and push fast. Meaning push hard, at least 2 inches should be pushed in, 5 centimeters should be pushed in, and hard, meaning 100 to 120 per minute. And most important is, apart from compressing, you should relax it so that the chest effectively recoils and the blood is received by the ventricles than before pumping. Next is to minimize the interruptions in compression. Mostly, you should change the compressor every 2 minutes because there will be compressor fatigue and effective CPR won't be possible. So, if there is advanced airway or not advanced airway, if you have not intubated the patient, better for every 30 compressions, 2 rescue breaths should be given. If you have intubated, then it is 10 to 12 respiratory rate per minute. How to check the effectiveness of CPR? You should check for the end-tidal carbon dioxide. Okay, yes. And what is the shock energy for defibrillation? Usually they tell use always the maximum dose available in your defibrillator, usually 200 joules. Okay, yes. Next is, if advanced airway is present, what you are going to do? It is 1 breath for every 6 seconds. It is 10 breaths per minute. Then PT ECO2, it should be more than or equal to 40 mm mercury, that means your CPR is most effective, and your arterial waveform, if it start to come again, that means ROSC has changed. After resuscitating a patient from cardiac arrest, you should always check for the reversible causes, which are the 5H and 5T. Hypovolemia, hypoxia, hydrogen acidosis, and hypokalemia, hyperkalemia, and tension pneumothorax, tamponade, thrombosis like coronary thrombosis, pulmonary embolism can be there, or toxins. All this should be ruled out. Okay, yes. So the answer to this will be, doesn't describe accurate CPR, they asked. Chest compression 100 to 120, we told push fast. Chest compression should be 3 to 4 centimeter. No, it is almost 5 centimeter you should press, 2 inches or 5 centimeter. Allow complete recoil. This is also good. 30:2 compression rescue breath ratio. This is also right answer. B is the wrong answer. Next, a male patient with purple striae, a male patient with a purple striae and thin skin, non-healing wound and pedunculated abdomen. Most probable cause: A. Insulin resistance, B. Hypercortisolism, C. Hypothyroidism, D. Hypercholesterolemia. So, what is this classical feature of your Cushing syndrome? So, what happens in Cushing syndrome is the capillaries are hyper fragile. They are super fragile. What happens is they spontaneously rupture, causing spontaneous bruising throughout the body. Even without any trauma, bruising might happen at any regions of the body. And also, if the patient is due to hypercortisolism, there will be deposition of adipose tissue throughout the body, giving rise to your moon faces, buffalo humps, pedunculated abdomen, all those things. So what will happen is the skin is stretched due to adipose tissue deposition. So usually in obese patients, the skin will be stretched and you will be having that classical feature of strain. But what differentiates this adiposity of Cushing syndrome is the capillaries are also fragile in added to the stretched skin. So what will happen? The capillaries can bleed in a stretched skin and this blood gets digested to give that classical purplish striae. Okay. Purplish colored striae more than 1 centimeter are very specific to Cushing syndrome and can't be seen in an obese patient, whereas white color striae are seen in obese patients. Then spontaneous bruising and purplish striae and proximal myopathy, 3 features which are very specific for Cushing syndrome. Okay, this you should be knowing. And relatively specific are your moon faces, pedunculated abdomen, buffalo hump, all deposition of adiposity throughout the body. So here, so you see, the answer is hypercortisolism, whereas your insulin resistance will cause skin findings like acanthosis nigricans, velvety patches in the axilla or back of the neck. Hypothyroidism, here the skin will be dry, alopecia. These features can be seen in hypothyroidism. Pretibial, swelling, pedal edema can be there. Okay, yes. Yes, so the answer is hypercortisolism. In hypercholesterolemia, there will be tendon xanthomas seen in the extensor tendons. Okay. Next, 10-year-old patient undergone some after some UTI. He was prescribed some antibiotics, following which patient had swelling of face and urine shows eosinophils and eosinophilic cast was found. The diagnosis they asked here, if you see tonsillitis, they are prescribed antibiotic. Post taking this antibiotic, patient had swelling of face and eosinophils are seen in urine. Eosinophils means some kind of allergy is happening. So the answer to this is, it is yes, acute tubulointerstitial nephritis. See, acute tubulointerstitial nephritis, most common causes drugs induced. It can be NSAIDs or antibiotics. If it is NSAIDs, then the type of hypersensitivity is type 4, cell-mediated hypersensitivity reaction. So here the cell seen will be lymphocytes, whereas if it is antibiotic, then it is type 1, meaning eosinophil-mediated hypersensitivity. So here the cell seen will be eosinophils, there the cell seen will be lymphocytes. And pathological hallmark, if they ask in tubulointerstitial nephritis, it is interstitial edema. Due to the inflammation happening, interstitial edema will be seen. Okay, so this is the histopathological picture seen. So what all you can find, interstitial edema can be seen, and due to this edema, the kidney will be swollen to give a enlarged kidney in your ultrasound KUB, and cast can be seen due to eosinophils that can cause eosinophilic cast in urine. Proteinuria will be mild subnephrotic range of proteinuria will be seen. This you should be knowing. And treatment is always to withdraw the drug away withdraw the drug, and if it is severe, you can give steroids since it is hypersensitivity reaction. Okay, yes. So the answer to this is drug induced. Next question, what they asked was patient with chest pain and fever since 1 month and breathlessness since 5 days. Chest X-ray shows cardiomegaly. Correct statement are all accepted. A, loudest one. B, pulsus paradoxus. C, emergency pericardiocentesis. D, in echo, diastolic collapse of right ventricle can be observed. So here if you see, they have given a patient is having chest pain and fever since 1 month, and now in last 5 days patient is developing breathlessness. So, and X-ray is also suggesting features of cardiomegaly. they are giving some history of like pleural effusion, which has pericardial effusion, which has progressed to develop into cardiac tamponade, and features are also suggestive of cardiac tamponade. So let's see what is pulsus paradoxus. So whenever during inspiration, what happens is there is a negative intrathoracic pressure will be there. So what will do? It will cause the stretching of the vena cava. So blood from the vena cava will drain into the RA and RV filling. RV filling will be enhanced, and during inspiration, more blood flow is going to the lungs, whereas output from the lungs to the left heart will be low. So RV will be overfilled and LV will be underfilled normally in inspiration. So usually your systolic blood pressure falls during inspiration, but not less than 10 mm mercury. See this pulse in this during inspiration, the systolic BP falls. So in cardiac tamponade, what happens is there is excess accumulation of fluid around the heart. So this compresses the right heart excessively. So what happens is the right heart can't relax and receive blood from the vena cava. So what will happen during inspiration? The only area which is relaxing, which can move is the septum part. The septum part moves towards the left ventricle and causes what happens? The left ventricular cavity is obliterated even more during inspiration. So what will happen? The systolic BP will fall even more. So this will cause to decrease systolic BP of more than 10 mm mercury during inspiration. If this is seen, then it is called pulsus paradoxus. This is seen in cardiac tamponade. Okay, this you should be remembering. Pulsus paradoxus. And also features of dextride you should be remembering: hypotension, muffled heart sounds, and electrical alternance in ECG. So in what is the meaning of electrical alternance? Meaning the heart will be swinging in the pool filled with fluid. So the heart will be swinging in one direction, that will contribute to one sort of QRS complex, and if it swings in the other direction, that will contribute to some low amplitude QRS. QRS will be varying in amplitude. This is called electrical alternance, and JP will be raised, which will be showing the JP signs in cardiac tamponade. It's important. Okay. Next is, so answer to this is the pulsus paradoxus is seen. Obviously, you should go for emergency pericardiocentesis. And in echo, that during diastole, there will be collapse of right ventricle will be seen. This is a finding of cardiac tamponade. IVC dilatation as well as diastolic collapse of the RA as well as RV due to compression by the fluid are features of cardiac tamponade. And heart sounds will be muffled, not loud as well. So answer is except. So muffled heart sounds will be seen. Answer is A. Next, not a complication of hypokalemia. A, BTAC, B, cerebral edema, C, diabetes, D, quadriparesis. This also we discussed in our revision video. It is nothing but hypokalemia always attacks the heart majoritatively. Like hypokalemia can prolong the QT, like hypokalemia, hypomagnesemia, hypocalcemia. All three electrolyte abnormalities can prolong the QT interval, which will lead to delayed after depolarization, leading to QT. Okay, QT prolongation, and that will result in ventricular tachycardia. As well as hyperkalemia can also result in ventricular tachycardia. You should know all these electrolyte abnormalities because these are reversible cause of PT. This you should be knowing. Next is diabetes insipidus. What is the cause of diabetes insipidus? Hypokalemia is a cause, one of the cause for electrolyte abnormality causing diabetes insipidus. As well as hypercalcemia can also cause diabetes insipidus due to destruction of the aquaporin 2 channels by this electrolyte abnormalities. Then quadriparesis, yes, this can be seen. We have seen the entity called hypokalemic as well as hyperkalemic periodic paralysis, where the patient will be having quadriparesis. So cerebral edema is not observed in hypokalemia. It is due to a complication of hyponatremia. Okay, sodium disturbances. Okay, yes. So answer is B. Next two questions they have asked regarding SGLT2 inhibitors. One is diabetes with heart failure with reduced ejection fraction they've given. Obviously, the drug preferred will be your SGLT2 inhibitor, which is empagliflozin. And UTI causing drug, and also you should remember, even in a heart failure with preserved ejection fraction, normal EF as well as mildly reduced ejection fraction. In all these heart failures, the drug of choice they have included as per recent ACA guidelines, your SGLT2 inhibitors. UTI causing drugs, yes, it is again empagliflozin. It can cause glycosidia, due to which fungal infections as well as UTIs are common. So answer all again it will be empagliflozin. Okay, yes. So these are the areas which should be focusing even for NEET PG, and I wish all the doctors going for NEET PG a huge success. Okay, thank you.